Good afternoon, everyone. I'm going to call us to order. I know you're all having a great time networking with each other, but I also know, do I dare mention what the temperature is outside? And no, don't sneak out during this. 10 below, and a snowstorm is coming. So might as well settle in with your coffee and a bar and hear us talk about connecting communities to advance population health. I'm Susan Heichert. I'm the Chief Information Officer at Allina Health, and it's my privilege to moderate this session. We will be here for about 90 minutes. We will be allowing about 20 minutes, 20 minutes for questions at the end. So if you have questions that come up during our panel, please do make yourself a note, and we'll be sure to get those at the end. This session is about connecting communities to advance population health. We will be talking with some experts here, a very esteemed panel, who will talk about how their strategies have been used to advance care transitions, care coordination, and population health. So is everyone at the right session? It's the only session, that's right. So first I would like to introduce the panel to my left here. We'll go in order. I'll start with Diane Rydrych on my left. She is the Director of the Division of Health Policy at the Minnesota Department of Health. And in that role, she oversees programs that develop and implement effective policy solutions for issues ranging from adoption and effective use of health information technology, patient safety and quality, health insurance access and affordability, cost of care, rural health care infrastructure, and healthcare work preparation, and other duties as assigned, obviously, and implements many of Minnesota state health reform activities. She also leads the MDH's State Innovation Model grant efforts, which many of you have been hearing about in the sessions today, in partnership with the Department of Human Services. Then to her left is George Klauser, who brings 15 years of nonprofit disability services experience to the collaborative, most recently with Opportunity Partners as president and CEO, board member, and volunteer. Other community work, including the Cerebral Palsy Foundation, United Way, and Courage Center. Mr. Klauser currently serves on the Allina Silos to Circles Task Force as a core team member, is an advisor and grant reviewer to community housing services, and is an advisor to the Behavioral Health Homes Task Force for the state of Minnesota. He currently co-chairs the Roadmap Social Service Committee and has been selected to participate on the SIM Community Advisory Task Force. Then to his left is Renee Frauendienst, who is a 27-year veteran in the field of public health and is recognized as a state leader in the public health system in Minnesota. She's contributed to the public health work around health equity, public health research, healthcare reform, and quality improvement. In 2005, Ms. Frauendienst was awarded the Jim Parker Leadership Award in honor of her leadership and innovation in the Minnesota public health system, particularly for the work she's done in the area of public health preparedness. Ms. Frauendienst is the current co-chair of the local Public Health Association of Minnesota Legislative Committee and the chair of the Minnesota Intercounty Association Public Health Section. She represents the local public health system on the Research to Action Network and the State Innovation Model Community Advisory Committee Task Force. Are you sensing a theme here? State Innovation Model, that's right. And then to her left is Dr. Rahul Koranne, who joined the Minnesota Hospital Association leadership team as Senior Vice President of Medical Affairs and Chief Medical Officer just in February 2015. Prior to that, he practiced in a critical access hospital system in Starbuck, Minnesota. Any Starbuck natives here? No clapping, huh? And he served as Vice President and Executive Medical Director for the Health East Care System, Community Services, Post-Acute Care, and Bethesda Specialty Hospital. Dr. Koranne attended medical school at the University of Delhi in India, where he graduated at the top of the university and earned an MBA degree at Carlson School of Management at the University of Minnesota. And finally, to his left, Dr. David Ross, who is co-chair of the Robert Wood Johnson Foundation's Data for Health Initiative, director of the Public Health Informatics Institute, and vice president of the Task Force for Global Health. Dr. Ross is on the leading edge in recognizing and interpreting the forces, trends, and technologies impacting healthcare and public health. He's an internationally renowned expert and will integrate the breadth of his experiences with findings from the new Data for Health initiative, providing his insight on the implications for what these findings mean for connecting communities and achieving our population health goals. So as you can see, we have a very esteemed expert group with us today. I think we'll have a lively discussion. We're going to kick off with Diane giving us a grounding in the context of population health. I'm sure I could ask everyone here for a definition and perhaps get all different definitions. And then we will continue on to some questions that we have for the panel. Thank you.
Thanks, Susan, and it's good to see so many folks still here. I don't know what the temperature is outside. I didn't know if that meant it's really good or really bad. So either way, I'm committed for the next hour and a half. So as Susan mentioned, I'm Diane Rydrych, and I direct the Health Policy Division at MDH. I'm always excited to be here at the eHealth Summit each year, and much like last year, I'm here at an afternoon plenary with a bunch of folks who I've been getting to know through SIM and who have been really, really active in those efforts. We have 3 of our 4 panelists who are part of our SIM Community Advisory Task Force. And it just strikes me that, you know, a lot of the conversations that we're having today, we wouldn't have been having a few years ago, and we wouldn't have been having in the absence of this kind of environment of change and reform and innovation that's happening. SIM didn't create it, but SIM has built upon what has come before, and I think is helping to accelerate it. And you'll see some of the implications of that here today. So I'm going to talk just really generally for 5 or 10 minutes about population health. And when I was asked to give an intro to this panel, my first thought was, are we all talking about the same thing when we talk about HIT and population health? Because I don't know that we necessarily are. And I'm not the first person to ask that question. Happily, for all of us, David Kindig, if some of you know him, David Kindig is a population health expert. He has worked to develop community health profiles that are available for a lot of different states. He wrote a great article just a few months ago for the journal Health Affairs, if any of you are subscribers, and it's called What Are We Talking About When We Talk About Population Health? And I think some of the issues that he raised there are really important context for the conversation we're going to have today. Even when we were preparing for this panel, and people were talking about how they envision population health within their organizations and how they view HIT as an enabler or a barrier to that. We were all kind of talking about different levels, and so I think it's important to kind of define our terms a little bit ahead of time. So when David Kindig asked this great question and then answered it, he referred back to kind of the traditional definition of population health, going back, you know, probably 80s, 90s, when that term started to come into vogue a little bit, and talked about it as the health outcomes of a group of individuals, and including the distribution of health outcomes within that population. Traditionally, it's a geographic population, can also be a cultural population, can be a disease-based population. It's different from public health. Public health, in this terminology, is more about governmental interventions around to improve population health, whether it's through screening or education or response efforts to improve the population's health. Could also be employees or members of a group. It's really important to note that when talking about population health in the traditional sense, so we're talking about a geographic area, a geographic community, but we're not just talking about outcomes for that community as a whole, we're talking about differences in the distribution of outcomes. We're talking about health disparities. We're talking about some of the issues related to health equity that Commissioner Ellinger spoke so eloquently about this morning. So not only how a group performs on the whole, but how they look when you break them up a little bit and you look at differences in outcomes. But the other way to talk about population health is the way that I think we've all become a lot more familiar with in the last few years, and that's in the context of the triple aim. So I noticed when I was going over my slides this morning that a few of them are the same as ones that the commissioner used this morning or that Dave Ross used this morning. I couldn't decide if that was a good thing or a bad thing. I've decided it was a good thing because it would allow me to go through some of these more quickly, but it also meant we're all kind of on the same page about what we're talking about. So we can reinforce some of the same messages. Unlike a few years ago, I don't think I have to explain to anyone what the triple aim is. I think it's really become embedded in the work that all of you are doing and is really an important guiding principle for us in our work across the system. But again, I think it's helpful to look back a little bit at what population health means in the context of the triple aim, because it's not necessarily the same as that traditional definition of population health. So the kind of godfather of the triple aim is Don Berwick, who for a long time was at the Institute for Healthcare Improvement, or IHI, and then for a brief and illustrious period was at CMS. When he first presented this concept of the triple aim back in around 2007 and 2008, he talked about it as both a geographic population and potentially a population of patients or subpopulations of individuals. But a lot of the discussion in the original articles about the triple aim was about patients interacting with the healthcare delivery system. It was about a population of patients or a panel of patients. He talked a little bit about social determinants of health and other factors that can contribute to an individual's health, but largely it was about the healthcare delivery system. So what that means in practice is that quite often when we talk about the triple aim and we talk about population health, we're talking about a panel of patients within an organization or within an ACO. It could be an attributed population. It could be just any patients who are within kind of a catchment area, or any patient who receives care, whether they're attributed or not. And that means that when we talk about improving population health, we're often talking about improving outcomes, clinical outcomes for that attributed population or that patient panel. So that was kind of the reason why he asked this question: what are we talking about when we talk about population health? And one of the follow-up questions in the article was, do we need a different term to talk about it? Do we need to clarify or differentiate between that kind of traditional community health and geographic population definition versus a population within a healthcare organization? He argues yes, and says we should probably refer to that kind of smaller definition as population management, or patient population, or population medicine. And it's important here too to make a distinction between population health and population medicine. So here's one of the slides that's pretty much the same as what Commissioner Ellinger had. It's important to talk about the distinction between health and medicine, or health and healthcare, because healthcare isn't in it alone when we talk about improving health. So as the commissioner noted this morning, and I think this is a good thing to reinforce, when we talk about what creates health within a population, whether we're defining it geographically, culturally, a population with diabetes, a population within a large employer, it's the healthcare delivery system that only determines one portion of that, probably about 10%. But it's the community in which you live, it's your health behaviors, it's genetics, it's your environment in which you live that contributes much more to creating health. This was one of the other slides that I think it's actually a good thing that both the commissioner and I raised this, because where you live really matters, right? And so when he talked about this slide, he talked about it in a context of health equity and structural racism and what the implications are for that, the fact that we have such striking differences across zip codes. When I look at it in the context of HIT and healthcare delivery, what it says to me is think about the different partnerships that organizations need to have, that providers need to have in one community versus another. Think about the social determinants that are in place in one community with a 70-year lifespan versus the 83-plus-year lifespan. Think of what that means for the practice of care. Think of what that means for improving population health within those different communities. Whole different set of partners that are around the table, whole different set of needs that need to be addressed. Partnerships also matter, and I think this is really the SIM connection when we're talking about population health. You've probably heard a little bit in different contexts today about accountable communities for health. What we're really trying to build with accountable communities for health through SIM is clinical and community partnerships to improve health within a community, driven by what that community wants. And that can't be done by a hospital alone. It can't be done by a clinic alone. It really does involve partnerships that might include schools, might include faith organizations, housing, transportation, social services, behavioral health. All of these different types of organizations have to contribute together to creating health. So when we talk about improving population health, whether we're using the big P geographic population or we're talking about the smaller P of a patient population or population medicine, those partners all need to be at the table for it. So just really briefly, when I then thought about HIT and how those different definitions of population health intersect with the ideas of HIT, there are a lot of different examples I can think of that are really supportive of improving population health, whichever way you slice it, right? So when I think of a clinical population, I think of things like real-time HIE, health information exchange between a hospital and a clinic and a long-term care organization to coordinate care for a patient that is shared across those organizations. I think of things like patient portals and engaging patients in their care and giving them access to information about their own care. clinical decision support to improve care for an individual patient, but also to look across your entire panel and look for trends, look for patterns for how you can improve care. But when I look at it from a geographic population perspective, there's kind of a whole different world that you can think about in terms of HIT and HIE. Within the health department, we think a lot about public health information exchange. How are providers exchanging information with us as a public health agency, whether it's for immunization or newborn screening or syndromic surveillance or whatever it is? Those are issues we have to think about as a health department. Regional health information exchange. Southern Prairie is just one example of that, but we're seeing different examples popping up all around the state, some of which you're hearing about today and will tomorrow, about using HIE to improve health in an entire region when all providers are on board and some of those key community partners are on board. Beacon, I think, is another great example that's looked at and is looking at in its next phase. How do you exchange with non-traditional partners like schools? How do you develop those partnerships and make sure that the exchange mechanisms are in place to improve health within an entire community, not just within one organization? But the thing that really came to me as I thought about this was that you can use the same mechanisms to impact population health, whichever definition that you're using. And I think ADTs was one of the best examples that resonated for me. So ADTs, admission, discharge, and transfer exchange, within an organization, I can use that to improve care for a patient. If I know that my patient has just had an admission to a hospital, that might tell me something that I need to respond to as the clinician caring for that patient. If I see a group of patients who are part of my patient panel, who've had a high number of admissions or ED visits, that tells me something about how I can better coordinate care for them. But if you look at ADTs as a way of coordinating care across a region, one great example of that is in Maryland, where they have a single state entity that's their health information exchange entity. All the hospitals are part of it. They're using ADTs on a statewide level to look at utilization across the entire system of hospitals and look at where there are pressure points in the system so that policymakers can think about what interventions might we need to use in a particular area, where might there be more support that's needed in a particular area. They're also using that information in combination with their healthcare homes to do hotspotting. So they're looking at pockets of high utilization, and then they're having community health workers go out and work in those geographic areas, those zip codes, to improve care and do outreach within those communities. So similar mechanism, similar HIT lever, but for used in very different ways to impact populations in different ways. I'm already out of my time, so I won't give the MIC example, the immunization example, but I think it's parallel. So I wanted to say that just as a bit of a lead-in to the panel. When they all talk about what they're doing with their organizations, they'll be talking about population health in different ways. One is not better than the other. One may be more about external reach within an entire community versus looking at coordination within an organization. They're both important. They're both key parts of the triple aim, but there are different HIT levers. There are different barriers or enablers that are in place, whichever way we're looking at population health. So the panelists are going to talk a little bit about how they're defining it within their organizations and how they're using some of those levers to move population health forward on each level. So with that, I'll turn it over to George.
Thank you. Good afternoon. It's great to be here. I am proud to be part of this group, and we come at this from a little bit different perspective, representing the community lens. So our ACO represents approximately 6,600 people with developmental or intellectual disabilities. And we started out about 2 years ago really looking at the entire continuum of services, from housing, employment, wellness, health, in both medical and behavioral health. And once we identified the delivery model for those services, much of which was in practice already, we really had to start to think about what's the continuum that ensures the person supported has and realizes healthy outcomes. So that led us to looking at a couple different variations from an eHealth perspective. So in parallel with our service delivery design and implementation, we also became involved in the eHealth design. And we found some interesting findings as we were approaching this. I think it's pretty well known that there are a lot of health disparities for people with disabilities, but we needed to understand why and what the gaps were. And through that process, one of the biggest gaps was lack of data to the care team. And in our lens, the care team is defined as both the community services providers as well as the health providers. And that lack of information was really leading to many gaps in that continuum. So our challenge has, first of all, been engaging the health, both the medical and the behavioral side, to understand this coming from the community side perspective, and recognizing that while those are social determinants, that they are also relatively important to a person with disabilities. So I was commenting at lunch that I probably spent the first year, and I know there were a few people in the room that were at forums. Jennifer Blanchard kept saying, George, you have to talk about what you mean about community health. But we've made a lot of progress in terms of education, that the way a disability services provider does think about it is in terms of what's the healthy outcome. It just was not clear to how we got there. So we identified the need to have a much broader look at the data, and our broader look at the data mirrors this continuum, looking at a complete client record, if you will, and we'll call him Jim, not only identifying Jim's home life situation, his employment, but certainly where he's at from a health status perspective. It has become less of a challenge and more of an opportunity now as we look at how we identify what that eHealth data record model looks like. And our ultimate goal is to ensure that everyone on the care team has adequate notification. So a simplistic example, thinking about it from the data perspective, would be that if Jim is injured in his job, that his practitioner on the medical side as well as on the housing side has notification of that, so that they can all participate in Jim's ongoing care. And through an alert system, updates are provided through the data model to that entire care team. Whereas in the past, we had these huge gaps in terms of providing the right care to ensure that Jim got therapy and was able to return to work. I think the other area that I would like to share with you in trying to achieve the strategies is the education process. You know, we all deal in the world of consents, and that also requires us ensuring that the guardian, the parent, and of course the client are open to the information flow that occurs in this continuum. So we have embarked on a very significant education process that really tries to be very offensive in trying to define what the need is for that information flow. And so far, we've had a few parents and guardians say, no, we don't want the medical professional to know about the social determinants. They're not important. So that forces us to get into this discussion of why they are important. And we've had the same on the other side of the equation. So I would say our biggest challenge today is education within our population, and really helping them understand the need for population health and overall data management.
Good afternoon. I am representing today the local public health system, and so I'm just going to put a little disclaimer out there that as I talk, I'm going to be probably more broad than specific as to things that my agency are specifically doing, and trying to maybe give a broader perspective on what is sort of happening out there in the local public health system in general. And as I say that, you just need to understand that as providers are on a continuum of people who, are well down the road of eHealth, and then you have people that are just moving into eHealth. Local public health is on that same continuum. You have agencies that are further down the road and have a lot more robust eHealth initiatives actually occurring. There are some in the middle, and then there are some that are just now coming on board. So as I speak to that, just know that there's sort of this continuum. So as I thought about sort of those activities and strategies that public health is engaged in, really what you need to understand are there are two levels that public health, from my perspective anyway, play within this. And one is a role of a provider. We provide services to our communities. So we do, as George, have clients that we are providing services to. So we look at things like exchanges and electronic health records and interoperability, and how do we use those to serve the clients that we're actually doing. And so as public health agencies have been looking at how do we take those systems that we use to document the work that we do and create measurability within those and create interoperability. And Diane alluded to some of those projects that are actually occurring, and I just recall hearing a conversation a couple years ago from the Beacon Project that was actually looking at asthma care in kids that are in the school setting and how they have been using interoperability and exchange. And when a child is hospitalized, the school gets notified and the public health agency gets notified, so they immediately know where their client is. And then once the child is discharged, what the plan of care is, and that's communicated out into the community. And it just creates better coordination for that child, and I'm going to guess probably improved health outcomes for that child. The other piece that I just wanted to let you know is that, as I said, not everyone's on the same page, so to speak. There is some information out on the Minnesota Department of Health's website around public health and eHealth, and there's some great information about sort of where is everybody sort of at in that information. So if you're ever interested in looking to see sort of where Minnesota at the local public health level is at, that would be a great place to go. And actually, I'll talk a little bit later about some percentages. But the second role that we have is sort of this broader, one of the 10 essential services of public health, and that's sort of monitoring what's actually happening within our community and then engaging our community in making change and moving towards this broader, improved health outcomes of a population, whether that's geographic or a specific targeted group of individuals. And really, we need access not only to our own data, but we also need access to the data that our community partners have. I was just in the session that was talking about advancing health equity, and there's some great projects that are going on there that it's taking like broad determinants of health and actually using that data to sort of identify where our interventions as a community, if we want to make a difference in the health of that particular population, how can we use that data to move that forward. And public health is very interested in not only that information, but how can we use that information to target the resources that we have within not only our own agency, but within the community as well. Again, with this whole goal of improving the health of our communities and creating equity within health of our communities as well.
Thank you. Rahul Koranne with the Minnesota Hospital Association, and I think what might be pertinent to know a little bit about me is I'm an internal medicine physician by background, and also a geriatrician by training and a geriatrician by heart. I think it's tough to follow what Diane talked about, what is population health, but I'm not going to follow my script, but I'm going to talk about an example that happened in one of our local communities and what played out over this last weekend as a way to start contemplating what is a population. And I really was struck, Diane, the difference between an attributed population to a health system versus the general population that the health organizations and all of us together. So it's not just the clinics, it's not just the hospitals, not just the assisted living facilities, not just the nursing homes, but it's also the schools and social service organizations. All of us health organizations kind of serve together. So so the attributed population, we all know, who's attributed to, based upon either primary care physician visits or specialty care physician visits or, the health plan or a governmental payer determining how do we attribute a patient to, let's say, Essentia or Allina or Hennepin Health or Altair. So there's the attributed population. But here's what happened in one of the smaller communities over the weekend, and I heard about it at one of our regional meetings this last week from the CEO of this health system. So MHA, Minnesota Hospital Association, represents about 145 health systems across the state of Minnesota, so hospitals and clinics and the extended continuum of care. So in one small community in western Minnesota, on one particular farm, some birds started dying. And a couple of birds died, and then a couple of hundreds of birds died, and then a couple of 100,000 birds died on this little farm. And so last week, about 30 white vans pulled in with some federal officials and federal workers who were temporary workers who came to clean up these birds that had been struck by the avian flu. So the workers came in, were cleaning up, they were wearing PPE, personal protective equipment, the right kind of equipment, and working hard, cleaning up the farm. And then 6 of those workers, I think I'm getting the number right, about 5 to 7 workers started experiencing flu-like illness. So then they showed up at the local emergency department. And they were temporary workers, so they were not attributed to this hospital or this clinic or to the system, and maybe didn't even have Minnesota insurance. And showed up in the ED, so the physician and the nurse practitioner are taking history, and they're like, oh yeah, you have flu-like illness. And so that to me is population health. That's when you serve the community, regardless of attribution, regardless of linkages to HIEs and HITs and HIDs, but you really are looking at the patient. And maybe I'm getting the HID wrong. I think it's HDI.
HDI.
But really the patient, the 6 individuals were in the ED, and the physician immediately followed the protocol and called Dr. DeVries at Minnesota Department of Health and his team. And so together, the CEO is informed. It's a small town, so the CEO shows up, and the medical director and the physician and the team at MDH is trying to figure out what to do for this population, these citizens, these individuals, and figuring out, is this avian flu? Is this influenza B? Is it just a common cold? And so that kind of stressor to the system, and it's not Ebola. It's not even avian flu. It turned out to be not even influenza B, I don't think. But that type of connectivity and serving the population, forgetting who's attributed to who and which payer types it is and what ethnicities there are, but it's really kind of pulling together to serve the community is what the health system is designed to do. And to me, that's population health.
It's really good. Yeah, I like the astute clinician is really a part of the public health system, no doubt about it. I think although those in public health, and particular public health preparedness, know that. I think it's a great story. I think of population health as a public health person, the big P. I come at it from the jurisdiction and the aggregate population level. As an epidemiologist, I think of denominators. But I think what the others have said also is quite true, whether it's the big P whole population or smaller subpopulations, and those subpopulations being panels of patients or specific groups. This is all part of our concern. As a public health type, Dr. Erlinger's comments really ring home to me because if you think about the whole of the population, you have to think about the whole of the population experience and what affects that whole population. And that could be the environment, it could be the economy. We know the strong correlation between economic downturns and increases in mental health admissions. So, I mean, there are all these factors that influence health of individuals and individual behavior. So I look at the big P that way. That's just historically my bias.
Thank you. Thank you for the answers to that first question, panel. And I think we heard some interesting ideas around needing more data, potentially, in order to accomplish some of these goals and aims that we've set out, and that education is also a very important connection, maybe not IT related, but without it, you can't achieve the aims that you set out to get to in the first place. So I'd like the panel now to consider the question about what are some of the bigger gaps and opportunities in leveraging eHealth, that specifically for care coordination, that you're seeing.
Well, first, I may have, excuse me, I may have to call Siri to top Dr. Koranne's story. So I reserve the right to do that. He's always one-upping me in these things. But seriously, I think when we think about care coordination, clearly one of the gaps we see is, first of all, providing that baseline of information to the care team, or specifically to the care coordinator. And how do we get from the current state of where we're at to what we would think about a more steady state of health? Oftentimes, when the care coordination kicks in, is based on a situation. So you're responding to a situation. We would like to get to a point where the data provides better access to the care team, so we are responding to a continuum. You know, we have a story about Jim, and Jim is a type 2 diabetic. Jim was passing out at work. Clearly, his insulin levels were out of control. He was not keeping his regular clinic appointments. He was refusing. The driver would come to the door of his community apartment. He would not answer the door to take the ride to the clinic. We advocate for independence in people with disabilities, so it was Jim's decision not to go to the clinic until ultimately his employer had to terminate him because he simply kept passing out at work. So that being the challenge, the solution to that again gets back to this better information. And had the guardian in that situation known that Jim was not keeping his medical appointments, there would have been intervention much sooner than it occurred in this particular patient case, because now we're left with Jim in a pretty serious medical situation. It also turns out he has a developing heart condition. He's lost his employment, and he's not able to pay rent on his apartment because he's not employed. So the opportunity in this is, if we are successful in population thinking and collaboration with information, we can really change outcomes. And we sincerely believe that as we look at this population and others. If we are successful I've talked to Marty in a couple different forums about this, even in the smallest case, if we are successful in implementing some of the initiatives we're talking about relative to health information, or we're wildly successful in having us all work together toward some common paths, I think we can really make a difference. And while I advocate heavily for education within my population, you know, what I've learned here today especially, and I was commenting to Jennifer about the strength of this conference over others, it's really connecting with me is we also need to be communicating about this on a pretty regular basis.
Ditto. Yeah, that was very good. You're going to have a hard time topping them. So, well, I'm going to come at this from a little bit different perspective in that as I thought a little bit about this, to me, we're on a very long journey. I was sharing with the group before that I actually came to the eHealth conferences many years ago when it first started, and my brain was taxed by lots of acronyms that I did not know, and a lot of technology. And it's kind of nice for me to now be able to come back again and to see that we're actually doing well in moving down the journey. But if you think about this, in my perspective, it's sort of like you're planning a trip and you know it's going to be a long one, and you think about all the resources that you're actually going to need to get there. And sometimes you have those things sort of packed, and then sometimes you actually don't, and you have to find ways to sort of get those tools that you need. So I think that's where we've been and kind of the journey that we're actually moving down. So when I think about gaps, some of it is as basic as we have providers who don't even have an electronic health record system in order for them to work in a coordinated care opportunity. Not that they don't want to, but they may not necessarily have the tools that's available to them. And again, looking at a public health perspective, not all public health agencies have electronic health records. If you look at the data that the Minnesota Department of Health has on their information, we still have 2 of our 50 community health boards that don't have an electronic health record. So it's sort of hard to have some kind of connectivity and interoperability and bringing them in easier than when they potentially would have the tools that they need. The other piece is that you may have the tools, but you may not have the connectivity. So again, if you look at some of the data that's out there, each year there's an assessment that local public health responds to the Minnesota Department of Health, and the most current data that they have out there is 2013. So each of these, as you go through each of these items, and I'm not going to go through a number of them, but we can identify who it is that we need to be connecting to, because we have care coordination issues that we need to be working through. So for example, of the 50 individual agencies responding, 48 of them said we need to be able to exchange with our hospitals. We know that that's going to be a priority if we want to do coordination of care. And yet only 21 of those 50 actually currently have the capacity to do that. Again, that interferes with the ability to exchange data and information. Same thing with clinics. We have 47 of them saying, it's important that we connect with our clinics, and yet only 20 of the 50 actually currently have the capacity to do that. So we have the beginnings of the tools, but there are still sort of gaps or challenges that are out there as well. And then the last piece that I just want to talk about is sort of this, the tools, but there's sort of this infrastructure and workforce that you actually need to have available. I want an informatician. And it's hard to say that word, but I want one of those. I don't have one of those. So every time I hear a bell ring, some public health agency has gotten an informatician, and I'm jealous. So, but they're the individuals that help you with, knowing what it is that you need to put into place. They're the ones that help you with project management as you move forward with making changes within the community. And they're the individuals that sort of help you forge through on, the eHealth initiatives within the community in a coordinated way.
So, just to finish my story, I was really struck, Dr. Ross, by what you said, the epidemiologist's view of the world. So this little farm and this CEO, the domino effect of the birds was a destitute family in the farm that the community was rallying to take care of, the temporary workers that were struggling. But then also there was the bird seed industry and the trucking industry. So everything, as it so happens, and as we all know, is interconnected. So care coordination and the challenges around that, I'm probably going to go in a third direction, away from the two of you. And so this is what's keeping me up at night these days, is the fourth of the quadruple aim. So I think we are all kind of well aware of the triple aim, and I think a lot, because we are in Minnesota, we are ahead of the curve, so we know what the quadruple aim is, and the fourth aim, which is our healthcare workers, and that includes volunteers, by the way. So that's, I think, the first challenge around, we can have all kinds of IT platforms that connect seamlessly with each other. But if we don't have the mental capacity in the nurse, who's either in the clinic acting as a care coordinator, case manager, or one of our nurses in the hospital setting, or one of the nurses, I really worry about the post-acute care nursing home nurses. So if I'm a nurse and I have a menu to fill out in the electronic platform, and that's what I do in my 8 hours or in my 12 hours, I think that's the biggest challenge in care coordination to me. If I don't, as a nurse, have in my mind the free space to think about, I am discharging a 82-year-old Mrs. Johnson to home. This is the third time she's come to the hospital. I've got all the boxes checked. I've done all the screenings, that the computer is telling me to do, and I'm just zipping through that, but I don't take a breath and say, this 82-year-old has a demented husband. Now, I gotta have space in my mind to think about what could happen, and maybe I need to think about some other, and our nurses do a brilliant job. So I think that's challenge number one, is not overloading our human resources, be it nurses, I worry about them a lot, or our physicians, or our therapists, or our pharmacists, or our volunteers. How can we make sure that the eHealth, and so I'm shuddering to speak this here, but I'm here and I'm loving the conversation. It's about eHealth, but it's also about our human resources. So when I talk about the paradigm of the triangle, the human resources is really the base of it. So I think let's think about how much we don't get too enamored with our electronic systems and we forget about the humans. So that's challenge number one for care coordination. Challenge number two is, we are all highly activated E-types in this room, and are we bringing our population along? So that's the other worry as a geriatrician. The thing that's flowing through this horizontal value stream is a living, breathing human, and with our demographic changes, sometimes the most costly or the most complex patients are our elders or our baby boomers or very complex patients. So are they activated enough so they know what's happening? Or is it just this e-connectivity around the human being? So that's the other challenge, I think, is bringing the human being, the patient, or the consumer along in new and different ways. And the third big challenge that I see, and that is keeping me up quite a bit at night these days, is the tug of war between privacy and the need to know. And where that rubber hits the road is mental and behavioral health. And so I'm transported 5 times by the police to the ED or to the state institution and back, but none of that is visible when I show up in the ED. So can I be served in the way I should be served? So there's privacy, there's mental and behavioral health, epidemic, and a broken system. So again, I think, as the ACO types and ACH types know, if we don't solve the mental and behavioral health dilemma now, we can have the most sophisticated E-system in the entire universe. We're going to not leave square one.
Very well said. Very well said. So I have nothing new to add to this. Because what I was thinking was really more eloquently said by my colleagues here. So I was going to say, so if it had started with me, I would have said it's the who, the how, and the what. That the who, the people, whether it's the public health department, the public health nurse who wants her informatician, or the nurse in the hospital. My daughter is one of those. Attending to what they need, educating them, training them. The work my institute does, part of it is informatics education. I can tell you one of our target audiences is leaders of public health agencies, to get them to understand enough about where we're going with eHealth to where they actually guide the health agency in a way that is becomes a supportive partner of the healthcare sector. The who, the how, the what. How we bring about care coordination takes, I think, a lot of understanding, as several of you said, and understanding and insight. The idea that the nurse helping a patient get ready for discharge is aware of that patient's context, and maybe in a really critical way. I've been a part of those conversations in a family way, where they're telling my senile father-in-law what to do, and I'm saying, are you aware that he won't remember this in 2 minutes? You should be talking to us. Let's, understand that interchange. But and what we need, I think, are tools. Renee pointed to that. But we need a number of tools, even something simple, I think, like making it easy for the clinicians to know where different services are that they want to point the patient towards. In most of my experience around the country, that's not information that's easily had. And consequently, even if the providers know what they want to do in a way of connecting that patient with other parts of the care system, it's not easy. And that barrier prevents it. So I think that's how I kind of look at ways to think through this dilemma and what would be those next steps. And I think there are some fairly simple things, at least in concept simple, to put together. We just haven't done it.
So it sounds like, in terms of gaps or opportunities, however you want to look at it, we have still some need for some tools. Some people don't have the tools, and a way to provide a baseline level of information to our caregivers and potentially our patients. But on top of that, we want to make sure that we don't get too far ahead of our human resources and our ability to think and use the tools in a way that blends what the tools bring as well as what we ourselves as healthcare workers, healthcare providers bring in creating this coordination of care. So given all that, I'd like the panelists to respond a little bit to how are you collecting data and analytics around this particular opportunity, and what are some of the tools you're using to do that, and what are some of the struggles you're seeing as you try to collect that data?
Well, our ACO has partnered with a community physicians group, and through their development, we now have what I would refer to as a common portal. So back to some of my earlier discussions, we now are gathering information from the care team on this common portal that can be accessed on a real-time basis for the care team. We are looking at some future phases that would give a client, a guardian, trusted advisor access. But today, this common portal is used. It can be accessed from your laptop, from your phone, whatever is available to you to access information on that person. I'm a storyteller like Dr. Koranne, and the story of Sally comes to mind. Sally is a client in one of our group homes. That's last year she was in the ER 11 times. This year she was in the ER up until probably April 4 times for an ear infection. Sally is 400 pounds, autistic and nonverbal, And inevitably, she wakes up with ear pain and a fever in the middle of the night, and the on-call physician, having no other choice, sends her to the ER. Well, now that we have assessed Sally through this community physician's approach and using a common portal, Sally's health history is well known. So 3 in the morning, again on this May night, Sally wakes up with this same condition, with the ear infection and the fever. A call is made from the direct care professional, who, by the way, in the group home has responsibility for 4 people during the night and typically is not able to leave unless they call in other personnel. The on-call provider is then phoned. The access is made to the common portal, and immediately she sees that Sally has had a history of ear infections almost her entire adult life. And in avoiding an emergency room visit, she quickly asks some diagnostic questions and determines that based on what the group home person is observing, Sally has another ear infection. So while she's going through that conversation, the care provider dispatches an amoxicillin prescription to the local pharmacy for delivery within the hour. The provider gives those instructions to the direct care staff. Immediately within that night, before morning comes, Sally is started on the amoxicillin for her ear infection. The provider stops by the next morning to check in on Sally and make sure it's not anything more serious. So what just happened? Through the power of data and a very comprehensive assessment that is gathered and maintained in this common portal, Sally, as the patient, has just had an incredibly improved health experience, much better than she's had the last 10 years of her life. She didn't need to get sedated to take the ambulance ride. She didn't have a 10-hour visit in the ER because it takes about that long to get her calmed down so she can just be examined. The group home staff didn't have to call in another person to come in and staff the other 3 people while they went to the ER. And now we have a history that's been that has been gathered on Sally for the next time. This kind of scenario is what we strive for in our first pass of looking at the importance of an integrated data model. As we look forward to this, of course, we want to start to derive some analytics to that so that we can better identify patterns to see if there are more Sallys out there in this situation, which we know there are. Better monitor how we are reducing ER visits in these cases where it's a situation that occurs and typically the only option is an ER visit. Start to look at ways that data can lead to not only supporting the triple aim, but focusing on how we can communicate better to the other care participants, both housing and also employment. And then also identifying how we can better understand secondary diagnosis like behavioral health, which, by the way, in the disability population, approximately 34% of that population has a secondary diagnosis of behavioral health. So wouldn't it be wonderful to have some leading indicators about that for the people we support?
So I'm going to take it up a little higher than the individual and maybe again start looking at some population. I have 2 stories I'd like to share with you. The first one is as a result of some of the community health assessment that we have done as part of our statutory requirements as a local public health agency. And one of the things that we've done for the very first time was we actually collected and worked with a contractor with 4 other counties to actually do some behavioral risk factors in assessing our community. And one of the things that came out of there was as we got our data back, we were looking to see that in fact our smoking rates in Stearns County was at 9%. The state is somewhere between 15 and 17%. And our partners that we had done this assessment with in other counties, were at the 15 to 17% as well. So, and I was going like, wow, that's kind of amazing. I was totally shocked. It wasn't what I was anticipating. And it would have been easy, I think, for us to just sort of say, well, we can tick that off. That's not a problem for us. But because it was so unusual, we actually dug deeper into the data and worked with our hospital to actually look at the data. And what we ended up finding is that when we broke it out by age, by socioeconomic factors, by sex, what we found is our male rate was at about 6% and our female rate was at about 14%. And it actually allowed us to go, okay, if we did an intervention, if we'd have just blasted out for everybody, I mean, how good of an intervention would that have been as far as trying to strategize as a community what we want to do with it? What's really interesting is that the partnership that we formed with our Center Care clinic system is that they actually were intrigued by that data, and so they went into their data that comes out of electronic health records, and what they found is a match. Is almost exactly the same thing. They took it a step further and actually were able to take some of that data and look at zip codes. And what they did is then overlaid on the zip code where they had elevated smoking rates, they looked at their asthma encounters in those smoking rates and found, of course, a correlation there. So again, it starts to target what kind of interventions as a community do we want to do in making a difference. The second story I want to share is we are one of the SIM accountable communities for health projects. And the last meeting that we had, Center Care had provided to us some great data that they had pulled out of their systems. And what they were actually looking at, we're looking at targeting interventions around diabetics for our Somali and our Latino communities within Stearns County. And one of the things that I found really interesting is that as they looked at factors that actually impacted those communities, what we typically see in interventions is control with that A1C evaluate or level, and then it's based on blood pressure, aspirin, and smoking. And yet when they pulled out our non-white community that they serve, what they found was the A1C, which was the same, but then it was smoking, and then blood pressure, and then the aspirin. So again, if we'd have just taken the data initially and said, well, overall everybody is these factors, and not really looked at how do we want to really target interventions as we move towards creating a care coordination system for those, targeting those individuals, we would have missed some of the boat by not really digging deeper into the data. What came out of that discussion was, and I shared this in the last session I was in, is that there was a lot of questions because we had a lot of our community members there who said, but you got to look at more than just like these interventions. It's like, do they have food? Do they have the appropriate food on the table? Do they have a transportation? Do they have all of these other determinants of health? And that's when our provider is saying, well, we have some of that data, but we don't have all of that data. And so there's a piece yet that is still missing that we're hoping to be able to look at collecting, because those are definitely things that impact the client's ability to participate successfully as well.
So what are the health systems across the state using, or what data collection paradigms they're using? I think that there's many different paradigms right now. I could mention a couple. So, some of the larger health systems I know are presenting today and tomorrow. You may have heard from some already. So there's some great work happening, Essentia, Avera, telemedicine, Mayo is doing a lot around telemedicine, so there's a great paradigm around collecting some of that data and how that is influencing the quadruple aims in the Twin Cities and surrounding areas. A lot of the healthcare systems, Allina and others, are doing a lot of work around, okay, so we have all of this data, what does it mean? And how can it actually be used by the caregiver and then by the active consumer that's kind of flowing through the horizontal value chain. So there's the big system, but then there's the small health systems. And again, when I say health systems, our members at MHA represent, clinics, post-acute care, hospitals, home health, hospice, ambulance companies, community health workers, and are trying very hard to partner with social service agencies and counties and others. So some of the smaller health systems are looking at Southern Prairie, for example, that was mentioned, and I know they're going to be showcasing some of their work. So the critical access hospitals, the smaller hospitals there, are starting to think about, okay, what are some of these social determinants and medical determinants together? What can we do together for our population / our community? So not just our attributed population, but our bigger community. So a lot of good work happening there. The 2 points I want to make, though, one is how much data is too much data, is where my mind goes to, and how many paradigms are too many paradigms. So there are a zillion ways of measuring value and quality. Now, Minnesota typically is ahead of the curve, so we have Minnesota Community Measurement doing some great work with our clinics and our health system. So we have had metrics. We've had the adverse health event reporting, that Diane and others have spearheaded. We were the first state in the nation to become transparent across and show our communities, okay, here's where we maybe potentially screwed up. And, that's not punitive. That's how we learn and how we improve. And I see that every day. We are improving constantly around that. Then there's other paradigms on, there's Medicare data, there's Medicaid data, there is each of the commercial payer has its own data, then, all of the IHPs, the Medicaid ACO has its own data, then there's the Medicare star ranking data, then there's each system or community collecting its data. So I think that's something for us to ponder regarding what's a unifying, is it possible in 2015 to start talking about a unifying paradigm of how value should be measured. And that's not just the health systems, that's the social service system, the Altair system, the governmental system. And I think some conversations are happening that really are exciting to me about, okay, there's a lot of data and a lot of paradigms, but as a state, what must we do now? So I think it's brilliant. The second point that I want to make, and before that, I'm just going to ask a quick question. Is there anybody that's a true consumer in this room? That's not from a healthcare system or health organization? Because I want to share a little, okay, so you can close your ears, because I'm going to share a little secret that we don't sometimes talk about. And, that's related to our data analytics work group that some of you are involved with, that's coming out of the state innovation model. So there was a data analytics work group. I was involved with that. Jennifer and many others, Diane, were involved and are involved with that. Do we know that we don't collect things the same way? I don't think we tell that to our consumers, right? We don't attribute patients the same way. We don't collect diabetic metrics the same way. We don't share, leakage, keepage data the same way. We don't even collect demographic and race the same way, So if we don't collect things the same way, then, I think I struggle to try to grab put my arms around, how do we start improving population health if we don't collect the demographic information for those who we serve in the same way? So this data analytics work group out of SIM, again, is trying to be courageous and say across payers, and Commissioner Jessen raised her hand first, saying Medicaid will step in and yes, we will join this effort and say we will collect things in a standardized way. So this particular work group came up with 5 data and analytics elements and all of the commercial payers were at the table. I mean, it was so impressive to watch. And it really passed all of the committees at SIM. And so we are proposing, so please watch this. I am watching this with bated breath. This could be revolutionary if all of the payers and collectors. So it could, it could be the accountable communities for health or, other institutions. If we can agree that a year begins on January 1 and ends on December 31st, right? I mean, that's when the attribution will be. The quarterly reports will be sent after each quarter. Demographics, we will collect age, sex, ethnicity, zip code, and address. Those are the kind of 5 elements that we decided as a community we will try to standardize. So I think it's not an easy task, but through SIM, Diane mentioned it, SIM has given us an ability as a state to race even further ahead of the other 49. So I think I hope we will use that opportunity to standardize in small ways, but then when our consumers ask, I went from my physician, primary care physician, to my nursing home, to assisted living, to the local group home, we will all be saying, yes, we know you, Mrs. Johnson, we know where you live, we're not going to ask it again. So I have great hope.
Wow. Well, we'll give you an award if Minnesota, if you can do this, because you will be showing the rest of the nation. One of the things our group does is work with data standardization. We do a lot of work, or at least over the years have done a lot of work with CDC, and I have to tell you, it's incredibly frustrating because, yes, can we all sit down and agree to define certain things in a consistent way? We should be able to. Recently, we've been having dialogue at CDC about why is it we need to have the several hundred surveillance systems defining fever in 15 different ways. And there isn't a good answer to that question, but it hasn't changed. I hope it will. We're working to help make that possible. That's one of the things we do. We also work on the analytics side. It's more about the kind of story Renee told, but we're in the process of developing what we call the EHR toolkit, something that Bill Brand actually directs. It's designed to help public health agencies partner with health systems to help the health systems use their data in ways that are beneficial to both parties. And I think that's where we're going to have to get in many locales, because the idea of actually forcing the direct exchange of the data to move it out of the healthcare system into the hands of a public health agency is, outside of legally reportable diseases, is often just not going to happen in many places. Maybe that's different in Minnesota, but in many other parts of the country, it just isn't going to happen. But what could happen is helping the health system use that data to understand it. So Renee, your story is, to me, sort of the metaphor of what I see happening in many places, and we're trying to help make that happen. And through our Informatics Academy, we're working to develop coursework about analytics, but that's still coming.
Great, thank you. So you've heard from the panel about some of the challenges that we certainly face, but how we continue to press on and have hope. That there are a number of different ways to get at this issue of how do we increase the availability of data to people so that they can perform in the areas of care coordination for us to meet our goals of population health. So now I'd like to open it up to you if you have any questions for the panelists from any of these areas that we've covered. You can either step up to the microphone or we can get a microphone to you. And if you don't have questions, I'll ask you some questions. No, no, I do have more questions for the panelists. Yeah, I think we have one over here. Yeah.
I got one. I'm Ken Zakin. I'm the consumer advocate on the eHealth Advisory Committee. Point one, we know it's not the same. But what I wanted to bring up under the topic of emerging opportunities, and it's something I've heard referenced at least 4 times today during discussions, and part of it even came up here, and that's the concept of caregivers. There was the example of one person brought up, they realized this person's caring for a dementia patient at home and such. I'm on several patient advisory councils, and this whole concept of caregiver continually comes up, to the point that many of us use the mantra that caregivers are patients too. And as such, that concept needs to find its way into everything that's going on here. Now, within the Minnesota legislature, I'm not sure how many people knew, there was a bill this year called the CARE Act that was submitted, and in a great effort of bipartisanship, it did pass the Senate 59-2, and that's where it ended because it didn't even make it to the House floor. But it will come up again next year, and this is just a first baby step that says, first off, that providers have to realize there is such a thing as a caregiver, which is different than someone who has medical power of attorney. The caregiver needs to be notified with a time period, I think, to be determined. I think it was like 4 hours, 3 hours, but you got to give the caregiver a heads up that the patient is being discharged. So the patient isn't calling them saying, hey, I'm here, ready, okay? And that the caregiver needs to get training on whatever at-home care needs to be done. This falls right into the rare examples and everything like that. So given that this is coming, and this is just the initial step, under the topic of an emerging opportunity or social attributes, how does that information find its way into eHealth so that we all understand what's happening there and begin to understand and address this upcoming trend?
Well, I'm going to try to take a stab at this. First of all, though, I want to thank you for volunteering your time on many PFACs. And that's something that is emerging in our community, and led by health systems, but led also by social service organizations and many others, and sometimes by patient advocates and caregivers themselves. What is a PFAC? It's a Patient Family Advisory Council on which you volunteer, and these are patients, actual real patients, so not a retired doctor or a nurse that's coming in or a pharmacist, real patients that are coming in and forming committees and advising the health organizations around strategies, around communication, around how to really be patient-centered and patient-led. So, the PFAC movement or the patient family engagement movement is absolutely on. So, to kind of get to your question on how does the information get to the caregiver, as I said in my mental and behavioral example, there is a push and pull between privacy concerns and doing right for the patient. So I, for one, and our association, and our members are absolutely taking steps to demystify medicine. Because I think that's the key to really getting to where we need to go. So do patients understand what is being said to them? Do neighborhoods and neighbors understand what is happening in their neighborhoods? County rankings, is that a best kept secret, or is that out there so that it's posted in schools and posted in neighborhood boards and posted in social service organizations so people can rally around what's happening in my neighborhood and what can I do, not just as a caregiver or a patient, but as a concerned neighbor. So I think the movement is on for sure, would be my perspective.
Any other comments from the panel? I would also like to respond to that. I think I can do that as the moderator. But I think you bring up a great point. We see this in some of the, if you will, mobile application space where people can invite other people to participate in their lives in a number of ways. Sharing how many steps you're taking on your Fitbit. Not that I'm endorsing Fitbits, but you understand. And as we get more and more connected through technology, we're putting the power in the person's hands to identify who is part of that circle and who gets communicated to. And I think as we move more and more in that direction, then we'll be able to have the patients participate in their care in a way where they're identifying who is in their circle of care, who can be privy to that information. And so when we're ready to discharge them, the circle is notified automatically, and they can come together as a community to care for that patient. So we had another question over here.
We've seen a couple of pretty well-known graphs now, one of which shows average per capita healthcare cost. And the USA is off the charts high relative to the rest of the world. And the companion graph is typically what, life expectancy, and it shows us no better than the middle of the pack. So my question is, as we talk about population health, are there lessons to be learned internationally that we might apply here.
So how will, as we continue to spend more and more on healthcare, how is that going to be reflected in better outcomes through the use of some of what we're talking about here applied to population health? Anyone care to respond to it? We'll start on the end with, yeah, if you want to pass that down.
Yeah, no question about it. The graphs you're referring to are real. We spend roughly twice as much as per capita as the next most spending industrialized country of the world, and get less in terms of basic health metrics. Life expectancy, you can almost choose the metrics. The curves all look the same. We spend too much, we get too little. But the extrapolation to how are these other countries working? Well, they're different in some ways. They're organized their healthcare systems differently than we do. They finance their care differently. But they're also, often this is the case, like Scandinavian countries, much more homogeneous, smaller, unified countries with a much more unified social sense. They have, by and large, social consensus that all persons should have access to health care. That still seems to be a debatable proposition in the U.S. So we seem, I think Churchill said it right, the U.S. eventually will do it, but after they've tried do it right after they've tried every other option. I think that's how I look at our transformation in healthcare. It's slow. We don't want to learn from lessons others are taking. I told the story about my wife and her broken back in Amsterdam. Taught us a lot about how a different approach to organizing those health resources is both more effective and lower cost. So I've seen it operate, and I don't really have any formulations of how we could do it better, but I think we can learn a lot by looking at other countries because they are achieving a lot at lower cost.
George, go ahead.
Well, I've kind of sung my song of mental and behavioral health twice already, but what the hell, one more time. That I think is something for us to really, really, really ponder. Again, I know we are thinking about it. That particular system is broken, and the health organizations themselves cannot fix it. So I think if we start thinking about eHealth and how we can leverage that, getting some privacy concerns allayed, working with some of our partners like police departments, like NAMI, like coalitions of patients, like patient family advisory councils. So that's the one big piece. I think we might be behind in figuring out mental and behavioral health. And then there's the opioid issue. And then there's the school system issue. So I think it's all interrelated under that big, huge bucket of mental and behavioral health. And the other point, I'm a geriatrician, and I'm on a panel, so I can't quite not talk about death. But that's the other piece to really think about. We don't do death right. We do not do death right in our communities. Again, I don't want to end on the negative note. There is hope. So there is the Gunderson Lutheran model that is here alive and well in Minnesota through a program called Honoring Choices. It's a program out of the Twin Cities Medical Society. Amazing work has been done around activating caregivers, activating patients, activating community health workers. So what don't we do right, and why might we be different? To me, it's those two things that make us, I think, a little different and unique.
Renee?
Yeah, I think I'd just like to add two things to that. One is I do think as we learn some of our lessons and looking at things that we're learning through the statewide health improvement plan, we're really targeting obesity and tobacco use, where we're really focusing in more on policy, system, and environmental changes. As the commissioner was talking earlier, let's create a community where the healthy choice is the easy choice or the easier choice. And what does that look like for each community? And each community is going to be different. I do have a story, though, that I would like to share. And the reason I like this one is because it's kind of a non-traditional health one. We used to provide jail health services, and a lot of people in jail are mentally ill or have some kind of mental health concern. And one of the things, as each year I was required to do, was to go to the board, talk to them about what were the pressure points, so to speak, in the jail. And in the early 2000s, one of the things is our costs were skyrocketing. And so I spent quite a bit of time thinking about what are we going to do about this? I mean, we have all of these costs that were going back and then over $1 million. So it was like, there's a lot of cost here. And actually began to think about, I'm a nurse, so what did we used to do in the hospital? Well, did we ever let people go out of the hospital without some kind of plan of care? No, we never did that. You know, we always had something that we were putting together. So why wouldn't we do that in the jail setting? So what we created was called the Release Advanced Planning Team. And that team involves not only the inmate, but also a group of people from our human services, as well as the sheriff's office, as well as the provider, as well as their correction officer, if they have one, or a social worker, if they have a mental health social worker. But about 6 weeks prior to that individual being released out into the community, we assess what the needs of that individual are, and we look at everything. What are their health needs? Do they have a job? Do they have a place to live? Do they have their medicine? Are they on health care services? I mean, those kinds of things. And the team really spends a lot of time meeting with that person, talking with them, finding out what the barriers are and putting those in place. So we used to send individuals out that were mentally ill with their medicine for 2 weeks. And then we'd say, and by the way, your psychology appointment or your psychiatrist appointment is 6 weeks out. So good luck for those 4 weeks that you're, don't have anything. And then we wonder why they come back 20 times a year into the jail. Hello.
And Renee, I'm going to let one more question come
Okay,
in.
I'm sorry.
But
Okay,
no, go
well,
ahead.
quickly, I just want to tell you, by doing that, we dropped recidivism rate for those individuals that went through the RAP by 70%. 2 years before, 2 years prior. After.
So one more
I'll
question.
be quick, Susan.
Yeah.
I know I'm eye on the watch. Jennifer Lundblad with Stratus Health. I first just want to add briefly to Rahul's answer to Ken's good question about caregivers. And yes, lots of our health systems are doing good work around patient and family advisory councils now, but I think we can turn to long-term care and the long-standing work with resident and family councils and groups that has been done there, because that's not only where those residents are getting their care, that's where they're living. And so they really know how to engage families and caregivers. So just wanted to add that. But my question picks up on where Rahul went. Rahul and Diane and I find ourselves in meetings often talking about the great tradition over the past decade of Minnesota leading in measuring quality and how we need the next big leap. Right now, we kind of seem to be plateaued and we need the next big thing. So I'll just ask really quickly of both George and Renee, have you begun to talk about how any new ways, any innovations in measuring the change in quality that you're seeing from these very community-based approaches that both of you are involved in and have just told such powerful stories about today? How can we take that next big leap in measurement, learning from the very specific community and local examples that you've shared?
In a sentence or two.
In a sentence or two, the good news is that there is more recognition in our community around quality. And I think for that reason, having the clients and the guardians more involved in that process is the next breakthrough. And I couldn't agree more with Rahul's example of the caregiver. I think we need to spend a whole lot more time training the caregivers so they can be contributing to that community plan.
Yeah, I would just add that, I think we'd want to look at their interaction with the system as well. My dad has dementia, and my mom is taking care of him. And so as a parent, as a child, those are things that you start looking at. So, but I think some of it, this is where our clients have to tell us their story. Because I think some of it starts with the story. Where it was good, where it was bad, and then to start looking at where are ways that we can potentially measure that more. Stories resonate with a lot of people, but some people need data as well, and so we have to, I think, sort of marry those two together.
Well, I would like to thank the audience for being so engaged and for your questions, and thank our panelists as well as Bob Johnson from the Minnesota Department of Health who helped organize our session today. So thank you. And we'll see you all tomorrow, bright and early.